Welcome back, our fans. A. Prognosis of plaque-induced gingivitis. If inflammation is the only pathologic change, prognosis is favorable. If inflammatory changes are complicated systemically, long-term prognosis depends on the control of B. Prognosis for patients with periodontitis. The overall prognosis. Prognosis for individual teeth. Should treatment be undertaken? Is it likely to succeed? When prosthetic replacements are needed, are the remaining teeth periodontally able to support the added burden of the prosthesis? Determined after the overall prognosis and is affected by it. 1. Overall clinical factors. A. Patient age. The prognosis is generally better for the older, shorter period in which bone loss has occurred in young one. Maybe because the younger patient suffers from an aggressive type of periodontitis, systemic disease, or smoking. High destruction in a relatively short period would exceed any naturally occurring periodontal repair. B. Severity of disease. Determinants. Bone loss. Cal. Root surface that is devoid of periodontal ligament. PPD. Less important. Angular. Intrabony pocket. More remaining osseous walls. Provide more protection for reconstructive materials. More natural sources of regeneration, osteoblasts, BV, biologic mediators. C. Biofilm control. Periodontal prognosis depends on the ability of the patient and clinician to effectively remove bacterial biofilm and resolve inflammation. D. Patient compliance and cooperation. The prognosis for patients with periodontal disease is critically dependent on the patient's attitude, desire to retain the natural teeth, willingness and ability to maintain good oral hygiene. Patients should be clearly informed of his important role in TTT. If a patient is unwilling to perform adequate biofilm control and receive the timely periodic maintenance checkups and treatments that the dentist deems necessary, the dentist can refuse to accept the patient for treatment. 2. Systemic and environmental factors. A. Smoking. It should be made clear to the patient that a direct relationship exists between smoking and prevalence and incidence of periodontal diseases. Smoking and healing. Therefore, cessation of smoking will improve the patient's chances of successful resolution of the periodontal inflammation. The predictability of treatment. B. Systemic disease or condition. Systemic disorders that affect the periodontium. Egg. Diabetes, nutritional deficiency, hyperthyroidism or hyperparathyroidism. Prognosis is good by controlling systemic disorder. The prognosis is hindered when surgical periodontal treatment is required and cannot be provided because of the patient's health. Some systemic diseases may limit the patient hygiene performance. Parkinsonism, paralysis. Electric toothbrushes. The influence of genetic factors on prognosis is not simple as it cannot be altered. C. Genetic factors. Early detection of patients at risk lead to early implementation of preventive and treatment measures. Identification of genetic risk factors later in the disease or during the course of treatment can influence treatment recommendations, such as the use of adjunctive antibiotic therapy or increased frequency of maintenance visits. Identification of young individuals who are at risk because of the familial aggregation seen in aggressive periodontitis lead to the development of early intervention strategies. D. Stress. Physical and emotional stress, as well as substance abuse, may alter the patient's ability to respond to the periodontal treatment performed. 3. Local factors. A. Biofilm and calculus. B. Subgingival restorations. B. Subgingival restorations. Subgingival margins may contribute to increased biofilm accumulation, increased inflammation, and increased bone loss. Even high-quality restorations with clinically perfect margins. The size of subgingival discrepancies and duration of their presence are important factors in the amount of destruction that occurs. Worst prognosis. Thanks for watching. Support us by likes and subscribes.